Yes, Seresha, we are live.
Yeah. Thank you, Ashwant. Ma'am, with your permission, shall we start, ma'am?
Yes. Sure.
Yeah. Thank you, ma'am. Good evening, doctors. This is Dr. Someshwar from Shield Healthcare. I welcome you on behalf of Shield. Thank you very much for joining today's webinar. I request all the delegates to please do comment your queries in the comment box so that at the end of the webinar, we'll have a short Q&A session. So now let me welcome today's our eminent speaker, Dr. Seresha Rao Chakraborty ma'am, who hails from the New Delhi, and she is a consultant gynecologist at Silchar Medical College and Hospital, and she's a registered under Gout of Delhi, and also at St. Stephen's Hospital, and associated with Project Matri in collaboration with Oxford University. And also she trained in colposcopy, and coming to the special interest in high risk pregnancy and fetal medicine and colposcopy. So with this, we welcome you for today's webinar, ma'am. And today's present webinar is streamed to the Shield Connect as well as a Shield Connect YouTube. And Shield Connect is a digital platform of Shield to connect all the doctors at one place. It's a digital initiative. We have blogs, webinars, awareness, and also our leaders page. If you miss any part of this program, it will be available in the Shield Connect. And also, if you want to read our leaders blogs, also if you want to visit any awareness regarding PCOS, women's health, anything GDM, immune boosters, COVID-19, also thyroid awareness, we have all the awareness pages available in the Shield Connect. So I request all the delegates, please do once visit the Shield Connect to visit all the, even we have a more than a 500 webinars videos available in the Shield Connect. So with this I conclude my introduction, and coming to the today's topic, as we know that dydrogesterone is have a many role, as it's a component of menopausal hormonal therapy, and also it is indicated for younger women with the treatment of dysmenorrhea, irregular menstrual cycles, premenstrual syndrome, and also it's effective in luteal phase support during the ART treatments. So now, without wasting much time, let me turn over the time to Dr. Seresha Rao madam to talk on dydrogesterone revisited. Over to you, ma'am.
Yeah, thank you so much. First, I thank Shield Connect and Shield Healthcare for giving me this platform. It is a very nice platform all over with different topics, and I always attend. I like the way it is being conducted. I thank the whole team for giving such a good platform and a good website for different awareness programs. So a very warm welcome to all of you. I'm Dr. Seresha Rao. Today I will be speaking about dydrogesterone revisited. We all know that dydrogesterone has been a drug for many long years, but in between somehow it was not well recognized, and now it has been again come into the limelight. So it has now become more important to be used more in luteal phase defect, threatened miscarriages, and in ART cycles. And there are many things which are associated with dydrogesterone, which we are still to know. So I would just like to brief you up regarding this molecule. So let us go once again to the history and the source and what is the pharmacokinetics, how does it affect the pregnancy, the early pregnancy, and what are its effects in the immune system also. So I would like to share my screen. I hope my screen is visible clearly.
Yes, ma'am.
So let us go to the topic directly. This is dydrogesterone revisited. So it is a progestogen. Now let us see what are progesterone. We all know progestogens are compounds which exhibit progestational activity, those which prepare the uterus for pregnancy. So it includes progesterone, which is the unique natural progestogen, and progestin, which is the term used for synthetic compounds which are designed to target the progesterone receptors and belonging to different classes of molecules with sometimes very different pharmacological properties and modes of action. So we know the natural is the progesterone, synthetic are structurally related to progesterone or to testosterone or related to spironolactone. So there are different derivatives, pregnein derivatives, 19 norprogesterone derivatives which are related to progesterone, and those related to testosterone, ethenylated and non-ethenylated, are the others. So what we are talking today is dydrogesterone, which comes in the pregnein derivatives, non-acetylated pregnein derivatives, which are related to progesterone. So what is the need for a newer progesterone? Now, the natural progesterones are not active orally. For many years, the intramuscular injection of progesterone in an oil base was most common. In 1980, an oral micronized form suspended in oil became available. Now, the synthetic analogs of progesterone have been developed to improve the oral availability and to produce longer lasting and more potent uterine effects than would be available from natural progesterone itself. Synthetic progesterones differ significantly from each other and from progesterone. So the biological activity of a progestogen changes considerably depending on the chemical structure, particularly with respect to pharmacokinetics and potency. So one of the biggest differences is their ability to bind to various steroid receptors. So in addition to action to progesterone, they can stimulate or block the other hormonal receptors, estrogen, androgen, glucocorticoid, or mineralocorticoid receptors. So let us come in the timeline to the history of progesterone. So Russell Marker isolated the steroid pregnenolone from the extract of pregnant mare's urine in 1936. So pregnenolone is then converted to progesterone, and then it is sarsaparagine is converted to progesterone using the new marker degradation technique. And sterol diosgenin was discovered from Dioscorea. So this is the whole history, and the Dioscorea is especially important. This Mexican wild yam species in Mexico, which is the main source of the dydrogesterone. So these are actually from the natural source. Dydrogesterone and micronized progesterone, these are both synthesized from the natural source. So both they are produced from the same Dioscorea plant. So this Dioscorea plant undergoes processing to becomes micronized progesterone, and in change to light technology bends the same molecule into a curved retrosteroid structure, which is the dydrogesterone. So a small change by light, which is shaped by light, enhances the progestogenic effects and brings the huge difference in this from micronized progesterone. So the source is a natural source. All progesterones, including micronized, are produced from these plant steroids, Dioscorea mexicana, which is a plant of yam family native to Mexico. So Dioscorea contains sterol called diosgenin, which is then converted to the progesterone. So in order to be used therapeutically, it can be micronized, it can be converted with UV light to dydrogesterone, or it can be compounded to 17 hydroxyprogesterone. So each progesterone is artificially manipulated and it becomes different forms of the progesterone. Now the structural modification is that it is a retroprogesterone, which is a stereoisomer of progesterone with additional double bond between carbon 6 and 7. So we can see that it becomes curved structure shaped by light with the extra double bond that improves the bioavailability, specificity, and affinity for the progesterone receptor. Now this is actually 6-dehydroretroprogesterone. So it is the only retrosteroid that is commercially available, and the molecular structure is closely related to that of natural progesterone, but it has an enhanced oral availability. So what are the effects? As we can see here, it affects the ovulation, it affects the post-ovulatory part, it affects the ripening of the sorry. Yeah. It affects the ripening, and then ultimately it helps in oocyte maturation. So we'll go to it later, what are the effects in the pregnancy and how does it affect the ovulation. So here we can see the pharmacological actions of dydrogesterone. So in the placenta and the decidua, the different effects. The maternal immune tolerance to the fetal tissues is affected. There is local generation of T regulator cells. This immune mechanism is there. I'll show you later what is. There's restricted accumulation of fetal T effector cells, epigenic silencing. So these, they're immunosuppressive molecules and decidualization. So let us see what are the effects of progesterone in early pregnancy. Now, normal natural progesterone is produced by the corpus luteum after ovulation, which prepares the endometrium for implantation. Now, if there's a failure in fertilization, the corpus luteum degenerates, there's involution, and if the fertilization is successful, the human chorionic gonadotrophin stimulates the corpus luteum to produce progesterone. Now, in the endometrium, the progesterone causes maturation of the endometrium, stabilization, helping in the implantation of the embryo, regulation of inflammatory mediators. So it causes adequate positive immune response in early pregnancy, preventing the pregnancy loss. So in early pregnancy, it is essential for pregnancy maintenance. The endogenous progesterone rises sharply after ovulation and peaks the following week, and it is produced later by the placenta through the HCG regulation. Now, we have a role in the miscarriage. That is why miscarriage is told as an untold grief. It is this, we know what is the miscarriage. So coming to the incidence of pregnancy loss, there are certain clinical losses, preclinical losses. So around 70% of conceptions are lost prior to live birth. So once a woman had a positive pregnancy test, there's around 12% risk of having a miscarriage. So what are the progesterone effects? Now, progesterone is actually derived from progestation, that is for pregnancy, pro for gestation. So the effects we have already seen that it prepares the endometrium, decreases contractility, regulation of cellular immunity, mediates the uterine blood flow, uterine endothelial adaptation to pregnancy, increased nitric oxide production, and drop in progesterone is possibly one step that facilitates the onset of labor. So in threatened abortion, also, there are many studies. The Cochrane collaboration also has shown us that progesterone is used for treating threatened miscarriage. So not all progesterones are suitable options. So we have this pure agonists, dydrogesterone, which are basically used. Now, progesterones have different modes and routes of delivery. So routes of administration, the oral, vaginal, and intramuscular route. So in oral route is the easiest route of administration and most acceptable route for the patient. And the vaginal administration has a higher uterine concentration, but it is usually uncomfortable in presence of vaginal bleeding, or it may be washed out if bleeding is severe. Intramuscular progesterone provides optimal blood levels, but it can induce abscess formation and extremely painful. So out of oral progesterogens, we have micronized progesterone and dydrogesterone. So we are seeing a comparison in, because we have seen the oral is the most convenient form. So in this, let us see what is the difference between the micronized progesterone and the dydrogesterone. So it has been found that dydrogesterone is more effective than micronized progesterone and standard care. There are many studies like Omar in 2005, El Zibdeb and Pandian. They have showed that significantly higher continuing pregnancy success rate with dydrogesterone. And Vinci in 2006, Tsiolkovsky and Pelincio in 2007, they have shown that dydrogesterone versus micronized progesterone, there is not significant difference in the miscarriage rate, but it has been seen that it is better tolerated and the dose required is much less. So the efficacy data suggests so there are many different trials, like 5 randomized trials were identified, including 660 women who fulfilled the criteria for meta-analysis, and the number of subsequent miscarriages or continuing pregnancies per randomized woman was compared in women receiving dydrogesterone. And they have found there's a significant reduction of 47% in the odds for miscarriage when dydrogesterone is compared to standard care. So coming to recurrent pregnancy loss, again, threatened pregnancy, threatened miscarriage, we have seen that there is no significant difference with the micronized progesterone and the dydrogesterone, but is definitely in relation to the standard care, the dydrogesterone has improved the pregnancy rates. So in recurrent pregnancy loss, we know that the most of them are unexplained, including non-APS thrombophilias, with 40 to 50% of unexplained causes, 17 to 20% of endocrine factors, 20% autoimmune, 10 to 15 anatomic factors, 2 to 5 genetic causes, and 0.5 to 5 infections. So out of these, the unexplained have been there no apparent causative factors identified in 50 to 75% of couples. So most miscarriages are sporadic and are thought to result from genetic causes that are generally influenced by maternal age. So in patients with unexplained RPL, the chance of successful pregnancy, future successful pregnancy, can exceed 50 to 60% depending on the maternal age and parity. Now in the workup, there are sufficient data to support the use of progestogens in the recurrent miscarriage. So here also, regarding the formulations, we have seen that injectable and subcutaneous used causes sufficient secretory transformation, but the adverse effects are there, including injection site pain, skin irritation, inflammatory reactions, abscess formation. And in vaginal progesterone, it is well tolerated, but adequate endometrial secretory transformation, but it causes discharge, vaginal irritation, and discomfort during administration. So oral progesterone is the most easiest route, generally most acceptable, and we prefer oral over the injectable. Now, as I've told you, out of oral, we have the oral micronized and oral dydrogesterone. So what the evidence says in recurrent pregnancy loss, that the patient convenience and compliance offered by oral route has encouraged manufacturers to come up with multiple formulations. So one is the sustained release formulation. So out of this, the oral dydrogesterone has evidence backed. So it is approved in threatened and recurrent miscarriage, also treatment of infertility due to luteal insufficiency and other progesterone deficiencies. Now, do the trials support the use in miscarriage? Yes, there is global evidence that 600 published articles and global evidences that oral dydrogesterone supports the prevention and helps in preventing the miscarriage. So is it available globally? Yes, it is available. And now the many companies have come out with newer preparations of dydrogesterone. So regarding the micronized progesterone, we have seen that there is poor bioavailability because despite the micronization, the oral micronized progesterone is still, the bioavailability is relatively poor with values less than 5%. The higher dose is required, like around 200 milligram to 300 is used. Adverse effects are the high dose causes in risk of intrahepatic cholestasis and is associated with drowsiness. So optimal timing, more dose of is particularly with sustained release formulation is still a challenge. So the better option has been found to be with oral dydrogesterone. So it has greater bioavailability. It has a unique structure that results in enhanced oral bioavailability of 28%, which is 5 to 6 times greater than oral micronized progesterone. And it is effective at a lower dose, only 10 milligram, 10 to 20 milligram is sufficient. And the adverse effects are negligible because it minimizes the activation of receptors other than progesterone. Progesterone shifts cytokine balance towards Th2 cytokine production, which is conducive to the success of pregnancy, and it improves the endometrial receptivity because it induces nitric oxide synthesis and improves the endometrial receptivity and pregnancy outcomes. So there are different meta-analysis and guidelines which say that for women presenting with clinical with recurrent miscarriage, there is a reduction in the rate of miscarriage with the use of dydrogesterone. So the oral dydrogesterone is also rapidly absorbed and it quickly achieves peak plasma concentrations compared to vaginal and intramuscular preparations. Oral 0.5 to 2 hours, intramuscular takes 4 to 5, and vaginal takes 7 hours. So 47% reduction in odds of miscarriage observed with dydrogesterone. So it has a documented evidence in immunomodulation also. Now we know that immunomodulation, there is it increases the PIBF production. It reduces the cytotoxicity of natural killer cells by blocking the degranulation and shifts the dominance from Th1 to Th2 cells. Let me just show you the immunomodulation. Yeah, so we know about the Th1, Th2 paradigm in pregnancy. So Th1 cells are the pro-inflammatory cytokines, which are cell-mediated immunity. It improves the pregnancy as less Th1 cytokines. So in a normal pregnancy, progressing pregnancy, the pro-inflammatory cytokines, the Th1 is the pro-inflammatory cytokines and Th2 are the anti-inflammatory cytokines. So Th2, the progesterone receptors are essential in maintenance of pregnancy, which is produced by the corpus luteum. So what happens? It increases the progesterone-induced blocking factor, PIBF. So it inhibits the production of Th1 cytokines and upregulates the production of Th2 cytokines, which helps in maintaining the pregnancy. So we can see here that in the normal progressing pregnancy, and when the PIBF is reduced, there is increase in the pro-inflammatory cytokines, which leads to miscarriage. So it has been found that dydrogesterone inhibits the interferon and tumor necrosis factor production, increases the level of interleukin 4, interleukin 6, and it induces production of PIBF. So the main metabolite of dydrogesterone also increases the nitric oxide synthesis by endothelial cells, and as a result, it helps in supporting the pregnancy. It retains the immunomodulatory effects of progesterone progestogen, dydrogesterone by bringing the shift in the cytokine production, and it suppresses production of pro-inflammatory cytokines and upregulates the production of anti-inflammatory cytokines. So coming to luteal phase defect, so there is a definite role in luteal phase defect by the dydrogesterone. Corpus luteum is defective in progesterone secretion, which in turn cause infertility or early spontaneous abortion. So if there's we go to the broadening of this definition, we can see a short luteal phase of less than 12 days with normal progesterone concentration relatively, or it may be inadequate progesterone concentration with a normal length luteal phase, or an inadequate endometrial response to otherwise normal progesterone concentrations. So it has been reported that luteal phase defect impairs the corpus luteum ability to produce sufficient progesterone. So when in the treatment of progesterone, the supplemental progesterone or is one of the supplementation is documented in luteal phase dysfunction, and it is commonly used when it can be assumed that luteal phase, especially during assisted reproduction, luteal phase support is always given. In majority of clinical studies, it is focused on this, and dydrogesterone is a very good molecule which is used for luteal phase support. There is studies like Balash et al. In 1982, which there are 44 infertile women confirmed in at least 2 consecutive cycles. Dydrogesterone, at least 3 months, or progesterone suppositories for at least 3 months and no treatment, success rate significantly was higher with dydrogesterone and progesterone rather than in control group. So pregnancy rate was 31% in both active treatment groups compared with 17% in group that received no treatment. So there are other studies like Malik et al. In 2000 also, infertility due to LPD, where they have found that 20.83% achieve pregnancy within the first month of treatment. So there are various meta-analysis of 69 randomized controlled trials which show that dydrogesterone versus placebo, placebo versus HCG, micronized progesterone. So all these results resulted in a significant effect in favor of synthetic progesterone compared to micronized progesterone. The only synthetic progesterone which was used was oral dydrogesterone. The route of progesterone does not seem to matter, but it was seen that oral gave much better results because of the acceptability. The experimental data in ART was shown by Chakraborty 2005, Patki 2007, Ganesh 2011. So these 4 prospective randomized and controlled clinical trials concluded that it is effective in luteal phase support in IVF. So the dose was 20 milligram per day, which was given. So there was it was concluded after all these studies that the significant effect in favor of progesterone for luteal phase support favoring dydrogesterone over micronized progesterone. Overall addition of other substances such as estrogen or HCG did not seem to improve outcomes, and average duration of dydrogesterone was up to 12 weeks, and there was no evidence favoring specific route or duration of administration. So there are various recommendations. There is a position statement on the use of progestogens by the Federation of Obstetrics and Gynecological Societies of India, FOGSI, which indicates beneficial evidence for the use of dydrogesterone. The most recent European Progestin Club Guidelines, EPC consensus-based recommendation suggests that a reduction in miscarriage is observed with the use of dydrogesterone for women presenting with a clinical diagnosis of threatened and recurrent miscarriage. Guideline of the European Society of Human Reproduction and Embryology recommends dydrogesterone where infertility due to luteal insufficiency is suspected. So as per the Royal Australian and New Zealand College of Obs and Gynae, the consensus-based recommendation for women presenting with clinical diagnosis of threatened miscarriage evidence suggests reduction in the rate of spontaneous miscarriage with the use of progestogen. So there are more than 55 years of clinical experience in so many women with more than 20 million pregnancies. So all these had led to different meta-analysis and many randomized controlled trials, and all these have found that the dydrogesterone is effective, and the safety records also are there based on the body of evidence for treatment of threatened and recurrent miscarriage. So it is, the main part is that it is metabolized into compounds which are also progestogenic and inactive, and they also help in the immunomodulatory effect. It has faster onset of action, long stable effect, better tolerated, favorable safety profile in all approved indications, and it is very similar to the natural source. So highly selective with a high affinity for progesterone receptors. It is also produced from, so this is a take-home message basically. It is produced from a natural source. What I've already told, that it is highly selective, it is metabolized to compounds, it has faster onset of action, it is well tolerated, and has a safety profile. So there are many studies regarding the safety profile also, because there were many questions regarding how safe it is. So there were many safety studies regarding the safety profile. So the Royal Australian and New Zealand College of Obs and Gynae 2013 says that there is no evidence of increase in the rate of antepartum hemorrhage, pregnancy-induced hypertension, or congenital anomalies. Wahabi et al. In 2011 also says there is no evidence of these complications, or nor in any occurrence of congenital anomalies on the newborn. Howard Carp also has shown that there are no side effects, including birth defects. So these are the safety and tolerability studies by in the 2013 Wahabi Howard Carp studies. So there is no question regarding the safety and tolerability, and the efficacy is undoubtedly, it has been proved by different trials. So we have the key message that there is no apparent causative, that the oral in recurrent pregnancy loss and luteal phase defect, oral dydrogesterone supplementation is reported to be beneficial. So it has become revisited. So we are using dydrogesterone. I personally am using dydrogesterone in most of these high risk pregnancies and recurrent pregnancy loss, and those with luteal phase defects, and I've got very good results, the successful pregnancy rates. So we have to think about which progestogen, we have to see which is suitable for the patient. And I personally believe that dydrogesterone has been proved to be much safer, much tolerable, and with much better efficacy rates. So I would like you all to think about dydrogesterone and see how you get the results better in if you compare it with other progestogens. Of course, depending on the patient profile, and the other factors have to be taken into consideration. So now dydrogesterone is also used in gynecological conditions. So I would thank you all for your patient hearing.
Yeah, thank you very much, ma'am, for the wonderful presentation. We are very honored and learning to hear you, ma'am. Hello.
Yes.
Yeah, ma'am. If you allow me, then we will take the questions.
Yeah, you can.
Yeah. Ma'am, we have a first question. That is, whether this dydrogesterone can be used in endometrial hyperplasia. Hello.
Madam, is it audible?
Yes, no, your video was not audible.
Okay, ma'am, the question was like whether this dydrogesterone was helpful in endometrial hyperplasia.
Yeah, there are certain studies, but basically I was more concentrated on the obstetrics. So there are different studies. Immunomodulatory effect has been seen.
Okay.
Rest, I'm actually focusing more on the pregnancy, early pregnancy, recurrent, and the luteal phase defect.
Yes, yes, ma'am. As in,
But it is used even in dysmenorrhea, it is used in endometrial hyperplasia, it is used in menopause also. So there are different fields now. That is why revisited now it has come up in gynecology. Also, there are so many places where dydrogesterone is being used. So we
yes,
have
yes,
to go more into depth in the gynecological segment. So basically, I was dealing more with the pregnancy and the support for pregnancy. The
thank you, ma'am.
the mechanism of action is basically the same. It helps in the nitric oxide synthesis, prevent the pro-inflammatory, helps in the supporting and remodulation.
Yes, yes, ma'am. Thank you, ma'am. And we have one more question, ma'am. Is it safe to use?
Safe to use, safety and tolerability. There are many studies. It is claimed to be safe, but it depends on the how the processing has been done. There is some factor that some percentage of how the processing has been done, which is approved at less than 0.5. So India has taken it to only up to 0.2 they have allowed. 0.05 is actually it has to be the during processing. So there is little factor in the original molecule. If it is not properly processed, it may give a chance of some changes in the carcinogenic. There has been studies, but then it depends on the how the molecule is prepared. So the original molecule which was prepared, that is totally safe. But now there are different companies are coming up, so we have to check the how is the purity and the efficacy according to the amount of the processing, how it is done.
Thank you very much, ma'am. I guess there are no more questions from the delegates. If you allow me, ma'am, then we'll close this webinar.
Yeah, okay, thank you.
Yeah, thank you very much, ma'am, for your wonderful support. We are very glad to have you, ma'am, and we look forward for your continuous support for the upcoming educational activities as well. Thank you very much, ma'am, and have a good day. And also, I thank all the delegates for their active participation. And if you miss any part of this program, it will be available in the Shield Connect webpage as well as in the Shield Connect YouTube. Thank you very much and have a good day, and many thanks from the Shield team.
Okay, thank you so much.
Thank you, delegates, for participating. Thank you all.